Test. Good morning. Thank you for joining our ERIDEX Symposium today. I need to apologize. There was some delays in preparing the breakfast, but it's coming for sure, so apologies for that. It's the caterer who didn't show up early. And thank you for Dr. Grippo, Dr. De Crom, and Dr. David for joining us today. They will, I think Dr. Grippo will let us know more about the content of this symposium, and enjoy it. Thank you very much.
So good morning, everyone. Thank you for joining us this early today. I hope you will enjoy the session and the breakfast. So the title for this series of presentations is A Non-Incisional Treatment Runway with Laser for Glaucoma. As a disclosure, I am a consultant and speaker for ERIDEX Corporation. And the objective is to review different laser treatment options that can help us cover the heterogeneous glaucoma clinical spectrum that we see in our clinical practice. We will be talking about MicroPulse Laser Trabeculoplasty. We will cover MicroPulse Transscleral Laser Therapy. And lastly, we'll talk about traditional CPC. Today, we have Dr. De Crom and Dr. Wu, who are joining us from Malaysia and the Netherlands. Dr. De Crom is a glaucoma specialist at the University Eye Clinic in Maastricht in the Netherlands, and it's a board member of the Dutch Glaucoma Group. He was also the first one in Europe to use the new revised probe for MicroPulse, and has been doing MicroPulse TLT for about 6 years now, and has huge number of cases. And Dr. Wu, he's from Malaysia. He's a consultant ophthalmic surgeon and assistant medical director of the International Specialist Eye Center of Kuala Lumpur. And he's also the lead resource coordinator for Ayer Eye Hospital Group in China. And he will enlighten us with his expertise on MicroPulse Laser Trabeculoplasty. All right, so Dr. Wu.
So, very good morning to everyone here. Thank you to Thomas for the kind introduction, and also to ERIDEX for the invite to speak this morning. These are my financial disclosures. Now, as most of you will be aware, laser trabeculoplasty is actually quite an old kid on the block, and it has been around since about 1979. And ALT, which is the original laser, was a blue-green spectrum laser with continuous wave argon. And this generated coagulative damage and cellular scarring at the level of the trabecular meshwork, resulting in an increase in aqueous outflow. But despite a couple of big studies, including the glaucoma laser trial in 1990 showing efficacy versus timolol, ALT as a whole concept never really took off due to a combination of maybe the advent of topical prostaglandin analogs, and also the fact that about 34% of patients developed intraocular pressure spikes following laser of about 5 millimeters of mercury and above. So laser trabeculoplasty pretty much remained in the background, usually as an adjunct to topical treatment. Now, in the mid-90s, we started having selective laser trabeculoplasty, SLT, which utilized a frequency-doubled Q-switch YAG laser. And this selectively targeted pigmented TM cells, and the result was less demonstrable histological damage versus ALT, and consequently lower rates of intraocular pressure spikes following laser. However, SLT never really gained any traction as a first-line treatment for treatment-naive patients, for example, until perhaps the publication of the LIGHT study in 2019 from London, which showed that in the context of the NHS anyway, in the UK, the light study was efficacious as topical treatment as a first line in early glaucomas, ocular hypertensives, and also a cost-effective measure for the healthcare system in that context. And this perhaps in the future going forwards is leading to more of an evolution in the treatment paradigm for glaucoma. Perhaps more of you now are considering first-line laser trabeculoplasty for your newly diagnosed patients. MicroPulse laser is an even more recent development utilizing sub-threshold treatment, and MLT generates multiple short on and off pulses of the laser, which allows the trabecular meshwork to cool in between the interpulse phases, and therefore this leads to almost no cellular or demonstrable morphological changes. There are two variants currently available. One is a 532 nanometer green laser and a 577 nanometer yellow laser, which I utilize. And one of the things I particularly like about the MicroPulse laser is its versatility in that there are retinal applications as well. I perform retinopexies with them. My retinal colleagues can do PRPs with them. And in particular for me, I also use it for suture lysis of external ligatures, which I place routinely on my Barvel tubes. So why consider MLT for glaucoma? Well, one of my ex-colleagues put it very elegantly to me. It's like SLT really, but with even fewer or no IOP spikes. And certainly in papers, for example, this one by Abramovitz et al. It has shown that they demonstrated that the post-laser IOP reduction is comparable between MLT and SLT, but for the MLT group, fewer patients actually experience discomfort during and also after the procedure. Another study by Hirabayashi et al. Has also demonstrated a reduction in the intraocular pressures following laser, along with a reduction in medications, which were comparable between MLT and SLT. But the authors concluded that about 10% of SLT patients experienced intraocular pressure spikes post-procedure, whereas none of the MLT group did. And I do find that this tends to mirror my personal practice, having performed SLT and MLT. I'll be interested to hear what my fellow colleagues on the panel think about that. There are three main potential MLT scenarios I would consider this procedure. One, first-line treatment in treatment-naive patients in an effort to either delay or do away with topical eye drops, which are pretty unpopular, as you would know. Number two, I would use them as an adjunct to topical treatment if the ocular pressures are not quite at target or if patients are symptomatic from the topical drops. Now, there is a final sort of, I would like to call them a last chance saloon patient category who are facing surgery with progressive disease, advanced disease. Now, these patients need surgery, there's no question about it. But there may be a variety of reasons where they either will decline or they are unsuitable for surgery, or they are unable to commit to surgery. For example, the very frail and very elderly patient may not be able to attend weekly follow-ups with me following either a trabeculectomy or aquashunt surgery. Some patients, so in my practice, there are about 20 to 30% of patients who actually fly into the country to see us. These patients may struggle with the follow-up regimes. Some people just simply need a little bit more thinking time, and therefore the laser trabeculoplasties can be considered, as long as they understand that this is not a replacement for surgery which they need, but maybe a temporizing way to get the pressures down a little bit more to afford them that thinking time. And if they're lucky, we may be able to avoid surgery altogether. But that's not the aim. And the fact that the MLT has such a low side effect profile means that the risk-reward ratio is pretty favorable, albeit with a guarded prognosis. Patients I would consider are the usual laser trabeculoplasty patients, OHTs, mild to moderate OAGs. I find that pigment dispersion and pseudoexfoliations respond particularly well to MLT laser, and I've also had pretty good results with the steroid-induced glaucoma patients with quite huge and sustained ocular pressure drops. Now, needless to say, patients to avoid would be the usual angle closure patients where the TM is not visible, and most secondary glaucomas where really we should be reaching for the aqueous shunts perhaps. Laser settings are pretty standard for me. It's 300 milliseconds, 1,000 milliwatts, and if you ignore the reading at the top, it's actually 300 micron spot size at a 15% duty cycle. If you press on the MicroPulse button on the machine, actually brings you up to a menu where you can select other duty cycles which may be used for other applications, for example, retinal, but 15% is pretty much the one to go for MLT. Lens-wise, you take your pick. I use the rich trabeculoplasty lens, but there are alternative lenses out there in the market. And the idea is to aim for the junction between the pigmented and non-pigmented areas, and in a fairly contiguous fashion, going 360. So most of my patients end up having between 150 to 155, 160 shots even. Post-laser, I don't usually give them anything, although one or two may require some topical non-steroidals for 2 to 3 days. I haven't actually needed that so far. Just a couple of cases to tie through how this might be this MLT laser may be useful. The first one's a pre-parametric glaucoma patient, a 30-year-old seeking a second opinion. He had been placed on a fixed-dose combination, preserved one for 2 years, and he had been putting up with redness, stinging, and photophobic eyes in the meantime. Vision was still good, 6.6, 20/20 in both eyes, but pressures were 31 on the right and 28 on the left, despite his reassurances that compliance was good, although this was possibly not the case. Gonioscopy revealed open angles and pigmented trabecular meshwork, so his corneas were pretty unhappy, pigment epithelial erosions. Corneas were not particularly thin. And visual fields were so not too bad at this point, although his optic discs were not looking too happy. The initial response was for me to place him on some preservative-free eye drops, which basically gave a fair reduction in his symptoms and also ocular pressures reduction, moderate ocular pressure reduction, but not quite enough. So MLT was performed at this stage, which afforded him a big IOP drop, even at 1 week without eye drops. And certainly in his left eye, this was sustained up to about 6 months with pressure of 15 and even 12 months at 17. The right eye has begun to creep up again a little bit, but this was still deemed acceptable. And because MLT is theoretically non-destructive, he has the option of further laser should he wish to. But he's a happy guy. And the second case is of a patient with a very advanced open-angle glaucoma to the right eye, not the typical patient I would consider MLT in. 64-year-old, he flew in from another state for a second opinion with this weird combination of first-line brimonidine for 3 years and then recently having a prostaglandin analog added. Vision was already starting to drop a little bit in the right eye with suboptimal pressures in his right eye. Again, open angles, pigmented with some peripheral anterior synechiae, but not too much. His ocular surface was not happy at all. He had meibomianitis, meibomian gland plugging, florid follicular conjunctivitis, and a visual field which we all hate to see at presentation. And at this point, he was advised he actually needs surgery, but he's one of them who couldn't logistically commit to surgery. Without even knowing when he would be back in the consultation room, we agreed we should probably just try some MLT, give him some thinking time and see where he went. But he was given the full counseling session for surgery and the poor prognosis he carried. Lo and behold, disappeared for 7 months. So starting pressures of 23 and 17, but sigh of relief when he came back and his pressure set 7 months with nothing else in between. was still 15 and 12 with a drop reduction. He had managed to reduce or stop the brimonidine altogether and remain on preservative-free prostaglandin analogues. So just in summary, MLT is a subthreshold partial duty cycle treatment method with fewer side effects compared to SLTs and definitely ALT. Versatility is definitely a bonus with retinal and glaucoma applications. 3 scenarios: first-line therapy, adjunctive therapy, and also your very advanced patients, as long as they understand why you're using the MLT. References on request, and I think questions we're going to take later, so I'll hand the session back to Thomas.
Thank you so much, Dr. Wu. Did we get breakfast?
Yeah, we'll be getting it, but they are still arranging.
Oh, all right, okay.
The truck that was bringing it broke down, so we are arranging for alternatives.
All right. So now I'm going to talk about MicroPulse TLT, and I'm Tomas Grippo. I'm from Argentina. I trained and lived in the US for many, many years, but I'm back home for the last decade. So what is MicroPulse Transscleral Laser Therapy? It's a treatment with infrared diode laser at 110 nanometers, and it's absorbed by chromophores like melanin much more than hemoglobin. So most of us are used to do traditional CPC. So what's different between MicroPulse TLT and the traditional CPC that we used to do in the past? There are basically 3 main differences. When it comes to the technique with MicroPulse TLT, most of us do sweeps instead of discrete spots. Then, in general, we use much less energy with MicroPulse TLT compared with traditional CPC. And the third and one of the most important points is that we use the MicroPulse mode when we do MicroPulse TLT versus the continuous wave mode that we use for the traditional CPC. And this is a little bit how the technique looks. We do slow sweeps, and we will be talking about sweep velocity later on. In the lower and the upper hemisphere, we usually try to avoid the 3 and 9 clock hours because of the vascular and nervous structures there. And it's a very short treatment. I mean, it's just a couple of minutes. And this is an example, a real example. What you see on the left side is with the original probe. What you see, the video you see on the right side is with the revised probe, the new version. And we always want to make sure that we have a coupling agent. But actually, Ron is going to talk in more detail about all how to do an appropriate technique. Now, some of you may be wondering what the MicroPulse mode concept is. What is it all about? And what it does, it controls thermal elevation by chopping a continuous wave beam into repetitive on and off short pulses. And by doing this, it diminishes overheating and potentially collateral damage. So what are the proposed mechanisms of action? So how does it work, right? So the first one is that there is a denaturalization rather than photocoagulation of the pigmentary, the one that has the melanin, and the non-pigmentary epithelium that's next to it. So when we apply the procedure, there is energy absorption by the tissues that creates heat, even though not an overwhelming high level of heat, that causes denaturation of the protein. So there is actually loss of function, and then decrease in aqueous humor production, and secondary decrease in intraocular pressure. So this is one of the mechanisms. And this picture down below, you may already be familiar with, is what you sometimes get with traditional CPC, right? I mean, you're getting the tissues to overheat, there is coagulation of the tissue, and then scarring. and there's a change in the anatomy that you're treating. This doesn't happen with MicroPulse TLT. The second mechanism of action is a pilocarpine-like effect, and Murray Johnstone was the one that proposed this. So when you're doing the procedure, there's contraction of the ciliary muscle fibers that pull from the scleral spur, and that stretches the trabecular meshwork. And if there are areas where there is collapse of Schlemm's canal, it may actually help diminish those areas of collapse, facilitating the egress of aqueous humor. And the third proposed mechanism of action is that you get a prostaglandin-like effect. So it increases the channels in the ciliary body and the suprachoroidal space, either by inflammation or scarring that facilitates this uveoscleral outflow. And this actually is a paper from 1994 where they showed what happens at the histological level with traditional CPC and scarring. So in 2015, now, of course, I was talking a little bit about CPC, I'm talking about MicroPulse TLT. So how do both techniques actually compare when it comes to clinical results? And the first one to do a comparison by doing a prospective study was the group from Aquino in Singapore, where they did a prospective study on patients with, I think they had like severe glaucoma, and they randomly assigned MicroPulse TLT or traditional CPC. And they followed those patients over about 18 months. And what they saw, you know, the study has some limitations. So it's not so easy to do a very straightforward comparison between both. But overall, there was a higher cumulative probability of success with the MicroPulse TLT. There was certainly a statistical difference in favor of MicroPulse TLT at 12 months, but that difference became non-statistical 18 months down the road. What was very clear was that the safety profile of MicroPulse TLT was much higher than traditional CPC. So similar efficiency and much better safety. So how does that translate into clinical practice, right? And the fact is that in general, we leave traditional CPC for refractive glaucomas as a last resource when everything else has actually failed, even though now there are papers saying that you can do it a little bit earlier too, using less energy. But this increased safety profile of the MicroPulse TLT actually broadened up the indication for this procedure within the glaucoma spectrum of patients that we see. And MicroPulse TLT is really, even though it's an evolution of CPC, it's a young surgical technique. And as every young surgical technique, there is an evolution over time. And I took this from one of the presentations earlier in the week, where you can see the different stages, right? I mean, the techniques evolve. You know, at the very beginning, there are a few surgeons doing it. You know, there are improvements on how to use it, how to perform it, until it becomes widely accepted and, you know, and used by everyone, right? So I think MicroPulse TLT is in this path. And it reflects even on my line of research. I've been doing MicroPulse TLT since 2016, and we've published, you know, plenty of work. And from the time when we started until now, I think we've learned a lot. And we are talking about an evolution, right? So what have been two milestones in the evolution of MicroPulse TLT? Well, one of it is the development of a revised probe. And the second one is a consensus document that we worked on for the last 2 years, and that was just accepted for publication. That I will be talking about and Ron later on. So when it comes to this new revised probe, what we have now is that there is no indentation on the probe, so there is no lacerations when we perform the technique on the conjunctiva. It's also easier because it has this bunny ears. It's easy to orient and place the probe at the limbus and perform the sweeps without losing our anatomical ground. And it also has this concave foot plate, which matches the scleral curvature. So there is better coupling and more stability. And stability is key, because when we're performing the application of the treatment, there is a cloud of photons that are coming out, right? So if we are changing our angle, it may affect, structures that we don't want to affect, like anterior structures of the eye. And it's important to highlight that it's critical to always use a coupling agent to facilitate the coupling between the probe and the sclera, right? And as you can see on the pictures on the eye here, you can see that with the new probe, the treatment is aimed more posteriorly, farther away from the iris root, the lens, the anterior aspect of the cornea. And that may limit the overall complication potential. So this is, with a new probe, it's been out there for, not that long, and now we are starting to see new publications with the use of this probe. And this is a paper that was just presented, a poster that was just presented at EGS by the group of Dr. Dorarash in Mayo Clinic. And what they did is a 12-month follow-up, a prospective study, 12-month follow-up, using, more conservative treatment parameters than the ones that we are going to recommend from our consensus, but about 50 to 60 seconds in different groups. And what they were able to see is they were able to decrease the pressure in one group from 29 to 17 at 12 months, in the other group from 24 to about like 14. There was not a significant difference in the number of medicines. And under just one treatment, and 15% of their patients required a repeat treatment, but everyone else did not. And out of those patients, 100% achieved a 20% reduction in pressure at 1 year, and 73% had this pressure reduction plus a final pressure below 21. And there were, again, no complications observed, at least in this cohort. And the second important milestone is this consensus document. And this group gathered from Europe, from the US, from South America. We got together and we tried to, the goal was to provide a peer-driven contemporary clinical guidance on the use and indications of MicroPulse TLT with a revised probe. And this was based on the fact that when we looked at the literature was a little bit confusing. And even, when you went to lectures, people would talk and do things significantly differently. So we just wanted, since there was enough literature and experience already out there, we wanted to come up with a consensus just to create the foundation and to facilitate things for, people that would not actually spend 2 years, working on this and reading all the papers to come up with the findings, right? And so we found 61 publications, we analyzed them. When there was not enough scientific evidence published for topics that we thought were significant for MicroPulse TLT, we did a 3-round Delphi method process to try to come up with these findings and conclusions from this group of experts. Then we held virtual consensus meetings, and we then submitted it for publication. And one was already accepted in clinical ophthalmology, and the other one we're about to submit, like the second part. And if you look at the flyer, which was around in the meeting, you can actually find the code, because these 2 webinars, which are about 3 hours of discussion and presentation of findings, are available online and YouTube, and also at the Iridex webpage. And if you're really interested in MicroPulse TLT, I would recommend you to go into that, because we have really touched everything about the surgical technique. And just some relevant findings about the consensus. It's important to realize that there is a sweet spot for the parameters used in MicroPulse TLT that allows a good balance between efficacy and safety. And so parameters matter, level of energy matters. And this range for the original probe was somewhere between 150 and 200 joules. And we also realized that to some extent we may be under-treating. And even though we now understand exactly, lower settings what is too low to get a good effect, we still haven't explored as well the upper range of settings that we could reach to maximize the efficacy of this technique. And we also realized that sweep velocity is very important. You know, how fast you do the sweeping is critical to allow the tissue to build up the temperature to get the effects. And this was not clear in the past. So we came up with some recommended settings that we believe are, you know, pretty conservative and should be reasonably safe for the majority of the cases that we treat in our practice. And this is with a new probe, with the revised probe. So it's 2.5 of power, the same duty cycle as usual, 31%, and 4 sweeps of 20 seconds per hemisphere. And as I said, these are the parameters that you could consider using for your routine cases. And if for some reason you decide that you want to go up on your settings, let's say because the baseline pressure is very high, the patient is on maximal medical therapy or has advanced disease, you may consider going up like a 25 to 20% in energy. And by doing that, you can increase the power, let's say from 2.5 to 3, or you can actually slow down the sweep velocity from 20 seconds to 25 or 30 seconds. Or you could add some more treating time. So instead of doing 4 sweeps, you do 5 sweeps. But don't do everything at the same time because you will be going up much more than 20% in your energy levels. And same thing if you just want to, you know, be more conservative, just go down 20% in your settings. In conclusion, MicroPulse, at least, well, this is personal experience and also consensus, but MicroPulse TLT is a useful addition to the glaucoma armamentarium. With proper surgical technique at energy settings within the recommended boundaries, MicroPulse TLT is a safe and effective treatment option for many types and stages of glaucoma. And we're talking about a glaucoma surgery, right? I mean, we know nothing is perfect in our glaucoma world. No surgery is 100% safe. I mean, we may encounter side effects, but overall, it's a pretty safe and effective technique. Design improvements in ergonomics and laser delivery have enhanced the procedure, you know, the revised probe and made it more user-friendly. And the consensus effort has actually allowed to standardize and have a more consistent understanding of MicroPulse TLT in general. And as I mentioned before, it's a technique that it's evolving. This is all based on the current knowledge. And as time goes by, we'll learn more and we'll be able to refine this even further. So thank you so much. I'm going to introduce you now to Ron, who will be talking, we'll continue to talk about MicroPulse TLT.
Yeah, thank you, Thomas. I don't know if breakfast already arrived. Yes. So for the people who want some breakfast, feel free to get some at the beginning of the room. I want to talk to you about which patients can be treated with the MicroPulse TLT. And Thomas already told, especially the last years, more and more papers became available in which patients can be treated, are treated with the MicroPulse TLT. And in our consensus meetings and search for answers to that, Thomas just said we did an analysis of the papers, 61 studies, and in areas where there was not enough evidence, we used the 3-round Delphi method to determine consensus in that areas. And the paper just accepted by clinical ophthalmology, so it became available within the next period for everyone who wants to use it. If we look into the literature, we see that a lot of different patients were treated with the MicroPulse TLT. And if we look at patients with different glaucoma types, patients were treated with primary open-angle glaucoma, angle closure glaucoma. Also, a lot of secondary glaucomas were treated with MicroPulse TLT. Also, patients with different glaucoma stages were treated with MicroPulse TLT. From mild disease to end-stage disease. And also patients with different lens conditions were treated, in variation from phakic patients, aphakic patients to pseudophakic patients. Also important, MicroPulse TLT was performed in patients who already received other ocular surgery procedures. Patients who already underwent trabeculectomy, tube implants, MIG devices, also patients after vitrectomy, conjunctival procedures, and after corneal transplants were treated with MicroPulse TLT. And in literature, we know that the MicroPulse TLT in all those patients had a very good safety profile. It could safely be performed in those patients with various glaucoma types, various glaucoma stages, the different lens conditions, and also after the various types of ocular surgery. We also know that you have to be careful in some patient groups, especially patients with scleral thinning, patients with a higher risk of postoperative inflammation, for example, patients with uveitis or patients after perforating keratoplasty. You have to be cautious with them. So we know that in those patients, MicroPulse has been performed with a good safety profile. But which patients in clinical practice do we think that you can very good treat with the MicroPulse TLT? So in our guidelines, we have some advices, and we give the following indications for performing MicroPulse TLT. And the first group of patients in which you can consider MicroPulse TLT are patients who are at a high risk or have no wish to undergo glaucoma surgery. For example, because of ocular factors, you can think at aphakic patients, which have a little bit higher complication rate if you want to perform a trap, for example, but also patients with a compromised conjunctiva. They could be very challenging to perform a trap or a tube in their eye. Also patients with a very end stage of glaucoma are suitable patients to perform MicroPulse TLT. Also other patient-related factors, for example, older patients or patients who are not able to visit you frequently after a treatment, are very suitable patients to perform MicroPulse TLT. A second group in which MicroPulse TLT can be considered are patients who already received glaucoma surgery. For example, a patient after a trap or a tube in which you want some additional IOP lowering, you can perform MicroPulse TLT in order to get it. You can also use it to bridge a period, to gain some time in patients with an uncontrollable intraocular pressure. Patients you want to schedule for surgery, but you have to gain some time because of, for example, blue thinners. You can use the MicroPulse TLT to bridge a certain period of time. Another category are patients who have a stable glaucoma but have a lot of medication, for example, 2-3 eye drops, mostly in combination with oral Diamox. And those patients you can treat with MicroPulse TLT in order to, for example, get rid of the Diamox. And at last, you can consider MicroPulse TLT in any part of the treatment algorithm after medications and SLT or MLT is considered. The treatment itself, Thomas already told you some things about the treatment. In order to perform MicroPulse TLT, a good anesthesia is very important. So you can do it with topical anesthesia. You can consider that in combination with sedation. In our clinic, we always use subtenon anesthesia. Also, the use of a coupling agent is very important to make a good contact between the probe and the ocular surface. And with the revised probe we use nowadays, the standard settings to start with are 2500 milliwatts, sweeping time of 20 seconds, and 80 seconds per hemisphere, which is the equivalent of 4 sweeps per hemisphere. And the placement of the probe is very important. So In the next animation and in the next image at the left, you can see the placement of the probe. You just have to place it 1 millimeter more posterior from the limbal area, and the sweeping velocity of 20 seconds per sweep is quite slow. And you can see it at the animation. If you perform it for the first time, especially if you are used to the 10-second sweeping time, it's very slow. So the treatment itself very fast, but the sweeping motion of 20 seconds is quite more challenging in the beginning. But if you're used to it, it's very good sweeping technique. In the consensus guidelines, we advise to see patients 1 week and 1 month after the treatment. Of course, you can see them sooner. Some patients, I see them 1 day after the treatment. For example, patients with a uveitis or patients after perforated keratoplasty. If I treat them, I want to see them 1 day after the treatment, just to see if there is any inflammation and to adjust the postoperative care if necessary. If we are speaking about the postoperative medication, the consensus guidelines say that you can use topical steroids, eventually in combination with topical NSAIDs, and you can treat it from 1 to 4 weeks after the treatment. In our clinic, I use both steroids and NSAIDs, topical, and I treat it only 2 weeks in a tapering scheme. Cycloplegia, antibiotics, they are not necessary, and if patients have some discomfort, you can prescribe paracetamol. But in clinical experience, most patients are quite fine after the treatment. If you look at what to do with the glaucoma medication, the topical glaucoma medications are routinely maintained afterwards. And oral medication like Diamax, sometimes you can stop it quite rapidly after the treatment, but overall you can withdraw glaucoma medication if you see a treatment effect. So if a patient visits you 1 week afterwards and the eye pressure is already becoming very low, you can start to withdraw some glaucoma medication. Are there side effects? Yes, but most of them are very transient and very mild. So you can see some inflammation, some keratopathy, also some transient hypertony, but they are very mild and not frequently seen after 1 week. Also macular edema and some persistent mediators are described in literature. For example, macular edema, if I look at our patient base, which already consists of 500, 600, 700 patients, I already see it with 3 or 4, so it's not very frequently seen in practice. And rarely phthisis bulbi of choroidal hemorrhages are described. If we look at repeatability of the MicroPulse TLT, some terms are very important to understand. So a non-responder is a patient that does not achieve and maintain at least a 20% of reduction in intraocular pressure within the first 3 months after the treatment. Early attrition is a patient that achieves the 20% IOP reduction within those first 3 months after the treatment, but does not maintain it during the first year after the treatment. And late attrition is a patient that achieves the IOP reduction for at least 12 months, but loses its efficiency beyond that period. We also know that there are some risk factors for retreatment or enhancement. So if you use a lower amount of energy and if patients have a higher baseline intraocular pressure, there is a higher chance that you need a second treatment to achieve your goals. And we also know that while the effect of the treatment may diminish over time, a retreatment has a very good chance of success, especially if you already saw that the patient had a very good reaction after the first treatment. So what do you have to do, or what can you consider if you see a response or a response which is becoming a little bit less? We think in our consensus guidelines that patients with an initial satisfactory response but has not reached the target intraocular pressure, you can repeat the MicroPulse treatment. And you can increase the total laser energy which has to be delivered. You can do it with adding an extra sweep at your treatment, or putting the energy a little bit higher. Just like Thomas told, don't do everything at the same time. Just choose to change one parameter of your settings. If you have a patient that does not have had an initial response within the first 3 months, the non-responder patients, it depends on the patient characteristics. If a patient has a very progressive glaucoma, you probably could advance to a different procedure. If you've got time, you can consider to do a second treatment with the MicroPulse TLT. And at last, if you have a patient with an initial good response and it loses its efficiency 1 year after the treatment or later, then an enhancement or retreatment is always a good idea in those patients. So we know that the place of the MicroPulse TLT in the glaucoma treatment algorithm is changed the last years. You can perform the MicroPulse TLT at different places of the total glaucoma treatment algorithm, and it depends on the patients, the ocular comorbidities, which you have to choose to do with your individual patients. Some cases, this is one of my patients with already a tube implant, quite good visual acuity and an intraocular pressure of 80, with quite a lot of medication. And you always have to question, what am I going to do with this patient? Do I give her a second tube? Do I do something else? In this patient, we performed a MicroPulse TLT. And we've done it in the days that we only had the original probe. And you can see that with one treatment, the last 4 years, the eye pressure remained very stable. And we also had a very good reduction in our glaucoma medications. So 18 before with a lot of medication, and now the last years around 9 with only a combination eye drop. A second patient is a little bit older. She already received a PraserFlow microshunt, but she had a very high intraocular pressure with a lot of medications. And she had a very bad conjunctiva, because otherwise you could perform a tube or a trap, but the conjunctiva was for very bad quality. So with this patient we performed also the MicroPulse treatment, and you can see that the reaction in the first 2 months was quite good. She received an intraocular pressure of 20. Also she got rid of the Diamox, but we wanted some extra additional effect on the IOP. So we performed an additional treatment with the Iridex laser. And we performed it, and you can see that 2 years after the second treatment, the intraocular pressure was quite good. So this was the part from the MicroPulse TLT I want to discuss with you.
You think you can go to conventional? It's 850. Yeah,
this is a little bit shorter. Because you can also do continuous wave cyclophotocoagulation. And if we look at the different ciliary body procedures, the more conventional procedures are, of course, the cryocoagulation and the continuous wave cyclophotocoagulation. And MicroPulse TLT, we already discussed it a lot today. What are good indications for the continuous wave cyclophotocoagulation? Of course, blind and painful eyes, neovascular glaucoma, refractory glaucoma with a poor vision or poor visual potential, and of course as a last glaucoma treatment. And what do you need to perform continuous wave cyclophotocoagulation? Of course, the system and the G-probe. And nowadays you've got the G-probe and the G-probe illuminated. And also here you have to use a good anesthesia. And the treatment, you've got two treatment techniques. You can use the slow coagulation technique, in which you use a little bit lower energy and a longer duration of your laser spot, and the classic POP technique, in which you use some higher energy levels with some shorter duration of the technique. And you treat mostly 270 degrees with 80 to 21 spots, and also here the placement of the probe is a little bit posterior from the limbus. How does it look like in real life? This is the POP technique, so you can see the probe is placed a little bit posterior from the limbus, and if you count, it's around 2 seconds per spot. This is when you use the G-probe. The G-probe illuminated is a very nice probe because sometimes the area you want to treat is a little bit more posterior than in other patients. For example, high myopic patients, the positioning of the ciliary body is a little bit more posterior. And with the illumination, you can mark the area where there is the border between the illuminated part and the non-illuminated part. And if you mark it, if you change sides, you can mark the other side. You can place the G-probe a little bit posterior from the marked places to perform your continuous wave cyclophotocoagulation. Post-operative, you continue glaucoma medication in the beginning. You have to use some steroids, atropine you can use, and mostly you can see the treatment effect 2 to 4 weeks after the treatment. Also here you can see some minor disadvantages, and also has some major disadvantages could occur with continuous wave transscleral cyclophotocoagulation. So that was a short wrap-up about the continuous wave cyclophotocoagulation. I think we have time for questions.
So for those of you who want to stay longer, and if you have questions or you want to be part of the discussion, anyone has a question? Please go ahead.
No, I understand it. It's a good question. We know it depends a little bit on your post-operative procedure. Most of the time, the treatment effect, you can see it 4 to 8 weeks after the first treatment. If you use steroids for 4 weeks, there could be some steroid response, so you have to wait a little bit longer. But in my practice, I use 2 weeks post-operative steroids. I see them 1 month after the visit, after the first treatment. If I see a good effect, it's good. If I see no good effect, I consider a retreatment 2 or 3 weeks later.
So around like 2 months, right? You would wait
Yeah.
before.
So the second treatment, I would not perform it before 2 months after the first treatment.
If the clinical scenario permits.
Maybe I can add to the question. How frequent, or how many times do you potentially repeat it? First question. And second question, are we maybe moving towards MicroPulse as a first line? Is that potential?
Right. You want to answer the repeat?
Yeah, the repeatability. I've got some patients which are treated at the beginning 6 years ago, And some patients received 3 or 4 treatments, but it is, there are quite a few patients who received a lot of retreatments, because you always have to see, can we afford it to do a retreatment, or do we have to go to another glaucoma procedure? But you can repeat it more often than we think, but we need more evidence and clinical experience to see which amount of retreatment is a good way to try.
Regarding your first question, if I may answer, certainly MicroPulse TLT is another tool that we have in our glaucoma armamentarium, and that's great. That has changed significantly over the last 10 years, right? 10 years ago, we didn't have so many options. So us, the consensus, would start considering MicroPulse TLT after we've used drops and after we've done laser trabeculoplasty, okay? And whether you decide to do a MicroPulse TLT or a different surgery will depend on the clinical scenario. And as I was mentioning, this is an evolution here, and it's still like a young technique. The literature is still building up. So when you're comparing it with other more established techniques, you may decide to do maybe the other one or this one. But I think time will really tell, once the evidence starts building up, whether we could, how to consider comparing to the other ones. I mean, I certainly do it in some patients. I mean, it's not a decision that I do all the time. It's based on individualizing the case, figuring out the options I have, and then deciding what I believe will be the best option. But I do consider it as an option. Ron, you agree with that?
Yeah, I agree. You always have to look at the individual patient characteristics. And when we started with the MicroPulse TLT, we started it with the patients at the end of the glaucoma spectrum. And when we saw the good results, we performed it with patients after traps and tubes. And when we see also the good results, we also treated patients in front of traps and tubes. So it depends on the patient characteristics and the progression rate, the IOP level. I think we can use it more and more in the beginning of the spectrum, but we need more trials and things to do to get more information about it.
I have a question. Yeah, go ahead.
I have a question regarding pain. So in my experience, patients treated with MicroPulse TSCPC have less intra and postoperative pain than patients treated with continuous wave. So what is your experience with that?
Yeah, I don't have patients who complain of the pain after the MicroPulse TLT.
So we believe that the pain really is when you do the procedure. So you want to make sure either that you block him, or you do a deep sedation, or you do what Dr. Totenberg does, this, his protocol of topical. But usually, in general, most patients don't have pain post-op. So if they have a little bit of pain, you can give them like some paracetamol or something like that. But it's not one of the main, it's not a main concern we have. And you're right with your impression. That's the consensus impression too, that usually patients don't complain of pain post-op or very little pain that goes away quickly.
And the procedure itself is painful. So if you don't use good anesthesia for the procedure itself, then it can be painful. But if you use good anesthesia, it's no problem.
Yeah, that's because of the ciliary spasm, right?
It still is the ciliary body.
Mm-hmm. Yeah.
How many times we can perform a retreatment, and what about the settings?
Yeah, it's just what we discussed. So you can perform it, especially if you have a patient who has a good result, and the effect of the first treatment fades a little bit away. You can perform a second or third treatment. If a patient don't have a good result, most of the time I perform a second treatment. If a second treatment don't have a good result, I do another glaucoma procedure. And what about the settings? if people have had a good result after a first treatment and the effect fades away 1, 2, 3, 4 years after the first treatment, I use the same settings. If a patient didn't receive a good result within the first 3 months of the treatment, I used to do an extra sweep. So instead of treating two times 80 seconds per hemisphere, I treat 2 times 100 seconds. So instead of 4 sweeps of 20 seconds, I use 5 sweeps of 20 seconds. But you can also keep 4 sweeps and power up the energy level.
Also regarding postoperative discomfort, pain, and complications, does it have a difference in hospitalization rates and the length of stay, or do you let the patients stay overnight at all?
No, I have never admitted a patient. Usually they do very well. I mean, once they get home, there are no pain. If you're concerned, you know, when you do the procedure, if you do it in the operating room, you can have the anesthesiologist give them some IV pain meds just for it to last like, you know, a day or so. But usually it's an ambulatory process, and there are people who actually do it in the office, even though it's a minority. So that's usually not a concern.
If you're doing laser as an interim procedure on somebody who you might ultimately do trabeculectomy or tube, what is the impact on conjunctiva? And do you spare the conjunctiva in an area that you might do a filter?
Yeah, I mean, in general, the outer surface of the eye doesn't get affected, even though, I mean, I've seen some reports of this is isolated reports of some scleral thinning, but in the vast majority of the cases, there will not be affectation of the conjunctiva of the sclera or the sclera, so you can do a trap or a tube need be. It's different from...
Yeah, and in addition, especially with the new revised probe, it has a very smooth surface, and the original probe, it had a little bit of indentation of the probe, so with the new probe, I don't see any difficulties, and I've got some patients in which I could perform a trap or a tube afterwards with no problems. So with the new revised probe, I've got the idea that there are no problems with conjunctival scarring or things like that.
Yeah, in most cases, unless they tell you, you wouldn't be able to tell if the patient had a MicroPulse done, I mean, from an anatomical standpoint.
I'm addressing to Dr. Wu about MLT. How do we adjust the parameters in this regard? Mainly the energy we provide. Now, we know that in order to be more efficient, we might modify the energy for each case. And what would be your guide to increase or decrease energy? And then if we adapt in more pigmented meshworks.
Thank you for your question. Certainly, compared to the SLT, it's a little bit weird when you first start doing MLT, MicroPulse Laser Trabeculoplasty, because you do not get that champagne bubble effect. So you almost have to go by blind faith that you're doing the right thing. I think most of us here use a pretty standard setting, 300 milliseconds, 1,000 milliwatts, 300 micron size, 15% duty cycle. And that seems to work pretty well. Again, 4 quadrants for me, about 130 to 150 shots contiguous. If the patient's experiencing a lot of pain, I may consider turning down the power, but I usually leave the duty cycle at 15%. And so far, in my cohort of Asian patients, anyway, very, very few people experience pain to an extent I have had to reduce the power settings, but very good responses, certainly with the pigmented trabecular meshwork patients so far. Thank you for your question.
With the MicroPulse TLT, is there any point in changing the distance? So now you said starting 1 millimeter below the limbus. because you do not exactly know where the ciliary body is, like one sweep at 1 millimeter, and another sweep like a little bit further, 1.5 or 2, and one little bit closer?
Well, the fact is that the anatomy varies between individuals, you know, the positioning of the ciliary body, and even within the same eye, right? So, and if you go to the extremes of, you know, big eyes or small eyes, that may be even more variable. So in general, we say that you want to error posteriorly rather than anteriorly. And that's the reason why we say, you know, you can put it either right at the limbus or just 1 millimeter posterior, but that's usually the range. If you have a very unusual, let's say a high myo patient, I mean, you may consider doing like a UVM or something just to measure like the distance and or do transillumination too. But for most cases, you know, within 1 millimeter from, you know, the surgical limbus, you should be fine, right? And that's a point that I want to raise is, you know, one of the side effects that I've seen, there was a poster out there, you know, a case series of 240 eyes, and they had like 5 cases of mydriasis. And one of the risk factors that we identified that the literature shows to be a risk factor for mydriasis is small eyes, you know, small anterior chamber, seen more often in Asian people. So you may want to be aware of those cases and maybe aim a little bit more posteriorly if you're going to be doing MicroPulse in those cases, just to diminish the risk of irradiating the energy too anteriorly.
And also avoid the 3 and 9 o'clock hours.
Oh yeah, that's
one of the most important.
There is consensus on that. What? Yeah, go ahead. Yeah, well, so that's the reason why we're saying, like, if usually you put it at the limbus, but if you want to error posteriorly, you can go up to like 1 millimeter. So in those eyes, I would certainly error more posteriorly. I would place it like 1 millimeter back.
Can I just ask, do you see a move from the MicroPulse to the traditional wave, replacing that in the future? So traditionally, our refractory cases, really high pressures, we're still using continuous wave, or would you think about using the MicroPulse cyclophotocoagulum first of all?
Yeah, I think there are some glaucoma subtypes in which we know that challenging that getting IOP reduction is quite challenging. For example, neovascular glaucoma. If you have someone with neovascular glaucoma, if you want to treat it with MicroPulse TLT, I use higher settings. I don't know what Thomas does, but if I have someone with neovascular glaucoma and I want to treat it with MicroPulse TLT, I use a higher energy level. I go up to 2750 milliwatts, and I use a longer period of treatment time. So I use 5 sweeps of 20 seconds instead of 4 sweeps. And I do that at the first treatment right now. If you use the standard settings with neovascular glaucoma, in my experience, the results are less than if you use the higher settings I just described. So for neovascular glaucoma, you can use both the continuous wave and MicroPulse. And yeah, we have to do more clinical research to see if continuous wave could be replaced by MicroPulse TLT, for example, that kind of procedures and patient types. But don't know what your experience is.
Yeah, I see it more as a continuum. The fact is that if you look at the evolution of traditional CPC over time, they're becoming milder with the amount of energy that they're delivering to the eye. And if you look at the evolution of MicroPulse TLT, we're becoming a little bit more aggressive with the amount of energy that we are using, right? So at some point, they may cross to some extent. That's the reason why at the very beginning of the lecture, I tried to highlight the 3 main differences between the 2 techniques. But there might be some, for some patients, I mean, there might be an overlap between both techniques. For some other patients, you may certainly only want to do a MicroPulse, and in some other cases, you may go go straight to traditional CPC.
It just seems that they're very hot and painful eyes, aren't they? So, and they're very inflamed to start with. So if you could do it in stages with the MicroPulse, that may work slightly more, be more comfortable for the patient in terms of getting it down, but with less pain, with less inflammation.
Yeah, you can also try to start with the MicroPulse TLT and see what the effect is on that eye. And if you see a patient has no pain, but the intraocular pressure is not getting lower, then you maybe you have to proceed to continuous wave. If you see a good effect and you want some more, you can add an additional MicroPulse TLT. So it depends a little bit on the patient characteristics.
Thank you very much.
Can you tell some your experience about secondary glaucoma after vitreoretinal surgery and silicone oil?
Yeah, very good. I think if we've got someone with secondary glaucoma after vitrectomy, especially with silicone oil, we've got quite a number of patients who received a MicroPulse TLT, and they are doing it very good. Yeah.
I have a couple of cases on whom I've had a very nice initial response. And there are people, you know, the issue with the silicone oil is the silicone oil, right? You just got to get rid of it as much as you can. And sometimes it takes, you know, several surgeries, several washouts. But I've combined washouts and MicroPulse TLT to try to stabilize those patients once the core of the silicone oil was removed. And it did help a lot. But you have to remember that the pathology is at the TM, right, mainly. I have like mixed experience with that, yeah.
Hi, can I ask, have you got any experience of doing transscleral laser under topical anesthesia in office rather than block or subtenons?
It would be great if Dr. Totenberg would be here. Actually, in the consensus, we speak about that, and he published, I think he published a paper on that, but he has this protocol where he instills lidocaine, and let it act for several times, for several minutes, for, I don't think, like 30 minutes, something like that, and eventually he does the procedure.
I've done both in the past, and I prefer subtenon, but it depends a little bit on your logistics, if you perform it in the operating room or in your office room, for example. If you use only topical anesthesia, like lidocaine gel, it can be enough. So if you use a lidocaine drop, lidocaine gel, in some patients that work very good, but in other patients it's still very painful. So it's quite unpredictable to use only that, in my opinion. If you combine it with some sedation, our colleagues in the States do that combination, it works very good. So it depends a little bit on your logistics and what you can offer in your operating room or in your office room.
Yeah, it's certainly something that you can do in the office, but the consensus is that it's so much more comfortable to do it in the OR, in a much more controlled setting. It's both more comfortable for you and the patient.
Yeah.
And I had one question for you, Ron. I mean, let's say if there are people who want to start doing MicroPulse TLT, are there any patients that you would try to avoid at the very beginning?
If you want to start,
if you're doing your first couple of cases and you want to be what's the ideal patient to start,
if you start
and the one you want to avoid?
With the patients who are at the end stage of the algorithm, so patients after with SECMA, very blind eyes, painful eyes, that are suitable patients to start with, to adjust your treatment technique and things like that. Patients after traps and tubes could also be good candidates, but you have to already have some experience with your treatment technique to treat them very good, because you have to skip the areas in which the tube is inserted or where the trabeculectomy itself is. Mostly the patients with where you want to perform the MicroPulse TLT as kind of last resort treatment are the most suitable patients to start with, in my opinion.
To start, yeah. I mean, I probably, we see like end-stage glaucomas or very cases like you described, but just post-RAP or post-tube, we have more of those patients. I consider those patients to be ideal to start. Someone who has a valve and the pressure is not ideal, and you want to do an enhancement, usually you get pretty good results with that. And regarding patients that you would like to avoid at the very beginning?
Yeah, I don't, if you start with the treatment, I think you have to be very cautious with uveitic patients. You have to be, you have to gather a little bit of experience how the eyes are reacting and how your treatment is going to be. Patients after keratoplasty could be sometimes challenging because of it's sometimes hard to see where the limbal area is exactly in those patients. Mm-hmm. So that's our, in my opinion, patients to be a little bit more cautious.
What about patients who are phakic, young, and do have some accommodation? How do you feel about those?
I treat them if necessary, but yeah, some people can experience the first 2 weeks some problems with accommodation. Some will have and some will have not, but it is always transient in my opinion and in my experience.
Okay. Anyone else? Any more questions? Well, thank you so much for joining us until now. I hope it was an enlightening session for everyone.